This is the first lecture that we will start today. It's about the burns. And the contents that I will discuss with you about burns today is discuss about the definition, how we define burn in the different types of burns or the different classes of burns, and then its epidemiology, pathophysiology, what are the effects that it creates on the body, how we classify the burns, what is the prognosis, and then the management task will start. How we'll manage it, the burns having specific features like burns having inhalational injury, how we identify and how we manage it. Then in the burn injuries, how we do the non-surgical management of the patient, like taking care of the fluid resuscitation, taking care of the nutrition, taking care of the general well-being of the patient, and then specific to the wound, the burn wounds. Okay, what is actually the burn? Can anyone define what is burn? Can anyone define what is burn?
It's damage in the skin due to chemical substance. We have 3 degree, 4 degree.
Okay, it is damage to the skin or damage to the tissue because of anything that causes injury related to the thermal element. So tissue injury that results from direct contact with flames, hot liquids, gases, even surfaces, like we call them friction burns, chemicals, electricity, or radiation. These causes thermal injury to the skin and the tissue, and this impact or this injury is sufficient enough to cause the disruption or the denaturation of the tissue, and sometimes it causes death of the superficial tissues. So just as we have discussed in the definition, there are different things that can cause the burn. It is not just burn by the flames. Burn can be because of the chemicals. Burn can be because of the hot liquids or gases. The burns can be because of electricity. It can be because of even friction. Sometimes patient presents to us with friction burn. What is friction? What is friction burn? Any idea? What is friction burn? Yes.
Traction bone.
Sorry?
Traction bone, broken bone.
Friction. Not fracture. I'm saying friction.
When the patient contacts fast with blunt force or other object.
Yes, when there is a rubbing of person's body or some tissue of the body with some object at a speed and with force, it causes disruption of the superficial skin and sometimes the deeper tissues also. There are not only friction burns, but sometimes there are avulsion injuries also. So friction burn is also, friction injuries are also a sort of burn. Okay. Why it is important to discuss in the plastic surgery? Because burns are associated with permanent disfigurement if not taken care of properly, and if not managed in time, there may be a permanent disfigurement and impairment of function also, because there is a loss of the skin barrier and the skin's temperature regulatory function is also disrupted. So there is impairment of the skin function, and patient may develop various infections which may be life threatening, or there may be some other complications or loss of immunity also. If we talk about incidents, burn injuries are more common in males as compared to the females, and there are 2 peak age groups. These 2 peak age groups are according to the exposure. The first peak is 20 to 29 years of age adults, because they are working in environments where they are more exposed to burns or the flames or chemicals. So this is the first peak, and the second peak is small children who are less than 9 to 10 years of age, And in these children, what is the most common cause of burn in children? What is the most common cause of burn in children? Faisal is here. Faisal Mujib. Abdullah Ahmed. Anyone can tell what is the most common cause of burn in children?
Hot liquids.
Hot liquids. Sometimes hot water, just by water, they develop burns, they develop scalds. And what is the reason behind it? That during
Kitchen.
in the kitchens.
Mostly abused.
They're clumsy, doctor.
Sorry?
They are clumsy as children.
They are clumsy, and if they are left unattended also, if they are left unattended and they are exposed to the areas of the kitchen or the washroom, they can go inside. Sometimes you can see that the kids, they are found sitting in the sinks of the washrooms. They open the tap unknowingly that they are opening the hot side or the cold side, and they can damage it. So they can damage themselves. So children are can say they are notoriable. They can have scalp burns, and is more common in the pediatric age group. Okay. The number of deaths per year is variable, and in the winter season, the number of deaths are more because of the housewife, because people are using heaters in their houses to keep the houses warm, and sometimes there are blasts, and sometimes there are the clothing or the carpets catching fire from the heaters and the other equipments that are there to keep the house warm. So the number of deaths are more during the winter season as compared to the summer season. Luckily, most of the injuries, they are less than 20% of the total body surface area and can be managed easily. And even for less than 10% body surface area burns, they are managed at home. We just give the initial care and then we send the patient home. And only 10 to 20% of the burns, they are of higher degree and they need specific care and management. Okay, this is the repetition of what we just discussed in pediatric age group. Scald. Do you know what is a scald? There is a term written here, scald burns. What are scalds?
You
Scalds are
have
the burning of fluids, Doctor.
Sorry?
Burning that caused by a fluid.
Doctor, burned by heat.
Isn't it superficial burns?
Scalds are, if you see this picture, just what I will show you.
صرخ يعني الظاهر يتذكرنا.
Look at this picture. What is happening here? What is this? This is a scald.
Third degree or
This
second?
is second degree burn. This is not a first degree. This is a superficial second degree burn. It is superficial second degree, not the first degree burn. First degree burn is just hyperemia. In the second degree burn, the zone between the damaged tissue and the normal tissue is filled up with fluid. You can see the edema layer between the superficial layer and the damaged layer and the normal viable layer of the skin. This fluid, it appears in the form. This is called scald. You have seen it yourself sometime when you get some burn by some hot thing. You develop a small blob, this blob or that bleb. We call it scald. Okay, this in the picture of this hand, you can see that there is a bleb formation, a blob formation here. This blob is called scald. Okay, so scald burns are the burns which are superficial burns, superficial second degree burns, and the edema fluid is separating the superficial dead layer of the skin or damaged layer of the skin from the deep viable skin. And this bleb is actually preventing the exposure of the viable skin to the outer world or to the infectious organism. It is actually a protective layer now. So that's why we say if there is a scald, if there is a blob, don't pop it, don't open it, because it is sterile. If you open it, if you try to rupture it, then it will become, it can cause infection of the underlying skin. Up till now, it is sterile.
طب دكتور الدكتور can open it يعني can يعني
If it
يعني
is big
discharge this fluid
enough,
from the skin.
if it is small, and if it is not causing problem, you can leave it, and management can be done other than this, because in here it will this is a bit bigger in size, but still it is causing the deeper tissue protection from the external environment. Don't work on it. If you want to put the gauze over it. No need to open it, no need to rupture it. Once there is a scalp, we don't rupture it. If it is too big and if it is causing problem, it is causing pain, then you can rupture it. Otherwise, there is no need of it. Okay, so in pediatric age group, because of the hot liquids, scalp burns, they're very common, up to 80%, and they account for 45% of the hospital admission. And they are also a category of the patient's presentation, which are called immersion scalp burns. And there are sort of child abuse. Sometimes it is noted in some children that the presentation of the burn is not usual. Usually, if a child will put his hand in the hot water, the whole hand will burn. The whole hand will burn like a glove, or the whole foot will burn like a stocking, or it becomes red or hyperemic like a stocking. But in the immersion scalp burns, if you see carefully, there are skip areas. There are areas where are burn, and then the normal areas. Like if a child is hold in his arms, in some person's arms, and he tried to immerse him in the hot liquid, what will happen? Some part of his foot will become burned, some part of his shin will become burned. He will try to protect himself, so some part of his heel will become burned. So when the child will try to protect himself, he will have skip lesions and burns. So if you are seeing a patient in the emergency with immersion scalp burns, and there are skip lesions and burns at the unusual sites in the buttocks area or in the area of the tip of the heels or the toes, beware that it could be a child abuse, and you should notify the authorities immediately. And one more thing is, this child should be taken should be given complete exposure, and should be checked thoroughly from head to toe, because if he is having these immersion scalp burns because of child abuse, he may have other injuries also. So in children, if you are if you see unusual pattern of the burns because of this immersion injuries, immersion in the hot water injuries, you have to take care of the child abuse factor also. Okay, the incidence is not very common in the elderly. Elderly group is not very commonly involved in the burn accidents, but the outcome is poor in these patients. Why the outcome is poor? Because of their own body status, because of their own conditions. They could have some pre-existing conditions related to the poor medical issues or chronic medical problems. They have a thinning of the skin with the passage of time. Or with the process of aging, the skin becomes thin, and the subcutaneous fat is not much in the elderly people. So they are having less, you can say they have less protective barrier as compared to a young patient, and their immune responses are also low. All these factors, as well as the other chronic medical conditions which are already in these patients, they make them more prone to develop complications after the burn. And the burn deaths of elderly patient, although incidence is low, but the burn deaths are more in the elderly population as compared to the young patients. So there are three main risk factors related to the mortality. If a patient is elderly, age more than 60 years, and if there is a total body area 40% that is burnt, and if there is presence of inhalational injury, these three risk factors, they are associated with a higher mortality rate, and mortality rate is more than 90%. Okay. Luckily now the burn deaths, they have declined. 10, 20 years back, the burn death rate was very high, but now it has declined. And what is the reason behind the decline of the burn deaths is because of the improvement in the medical care, improvement in the protection gears that are available, improvement in the medical emergency medical services. Then at home, people now utilize the smoke detectors or the fire alarms. Then better education of the parents, and on the other part, if they educate the kids, that is also one of the important factors. Nowadays in the schools, they are educating the kids how to take care if there is a fire, and how they should protect themselves. So all this has contributed to the decline of the burn deaths in overall ratio. But still, what is the leading cause of morbidity and mortality in the burn patients? What do you think? What is the leading cause? If we are saying that burn causes an impact, and there is a lot, there is
infection, Doctora.
very good. Infections, because we just said that skin is a barrier. Skin is a barrier to infection. When the skin is lost, body is externally exposed to a lot of microorganisms. And initially, the most common organism that is usually found in the burn wounds, they are the Staph aureus. But later on, as the time passes, the gram negative come in action, anaerobes come in action, and then these anaerobes and gram negatives, they are very difficult to go away. They destroy the grafts if you have put the grafts in the body, on the skin, and they are the factors that will lead to sepsis and septicemia, and they are the major causes of death in these patients. Second, apart from the skin, there is another primary source of infection, that is the lung. Inhalational injuries, they are also one of the factors that causes the lung to be affected, and the lung is also one of the primary source of infection in these patients. Okay, what is the pathophysiology? What is happening in these patients? The first thing is, as the skin is damaged, so there is no control of fluid loss. So there is significant increase in the fluid loss from the extremities, from the body surface areas. And because of the inflammatory response, the first thing is loss directly. Second thing is the inflammatory response loss of the fluid. When there is inflammation, the fluid tries to come out of the capillaries and accumulate in the interstitial spaces, leading to edema. So there is twofold loss now. The first loss is because of the skin loss, and the second is because of the edema that is causing the fluid to come out of the capillaries and accumulate in the interstitial spaces. So if you see, there is a rough estimate that if you see a leg diameter of a patient, which is more than 2 centimeters as compared to the normal side or the normal unburnt area, it roughly says that almost 2 liters of fluid has been accumulated in this leg because of the edema. 2 liters of fluid has been taken out of the capillaries, and it is now lost in the interstitial spaces. Okay. Second is the loss of epidermis also causes loss of the bacterial barrier. There is contamination or superimposed infections, leading to sepsis and death. Keep one thing in mind. In the very first time, the very first day of the burn, patient is sterile because the surface area is not exposed to, at that time, it is not having any germs. But there is superimposed infection in the coming days, and the first organism to infect is Staph aureus. With the passage of days, the Staph aureus colonization becomes low, because now the gram negative and anaerobes, they come and they start colonizing the burnt surface area. So this is not just one organism that is involved there. Multi-organism problem or infections are responsible for the sepsis, and this is also one of the most common cause of the death of these patients. Okay, the effect of burn injury is it causes destruction of the tissue depending on how much time the heat was in contact with the body. And what is the causative agent? Is it chemical? Is it electric shock? Is it flame? So the destruction depends on what is the type of causative agent and how much is the contact time. Uh, the loss of barrier lead to infection. There is fluid loss from the surface, and there is red cell destruction, especially in the cases of electrical injuries. The increased capillary permeability causes edema, loss of circulating body volume. Patient can go into hypovolemic shock. Okay. The morbidity and mortality depends on the site, extent, and depth. This is just the revision of all the things we have discussed. Now there are early consequences that we have already discussed, the hypovolemia and sepsis. Short-term consequences can be renal failure because of severe shock, because of severe hypovolemia. It could be respiratory failure because of inhalational injuries. It could be catabolism and nutritional depletion because of inadequate nutritional replacement after the burn. Venous thrombosis and curling ulcer or erosive gastritis. And long-term consequences can be permanent disfigurement because of the burn, prolonged hospitalization causing economical burden to the patient, psychological problems, and impaired function overall. Okay, when a person comes into contact, now I'll talk about the pathophysiology, how the burn injury occur. When the person comes in contact with the hot thing, with the thing that causes thermal injury, the area which is in direct contact with the burn, it undergoes coagulation. We call it this area which is in direct contact, that area is called zone of coagulation or the zone of thermal coagulation necrosis. This zone of coagulation is the central part that was in contact with the thermal injury. Then we have leave the second part. Then we are going to the outermost part that is more closer to the viable tissue. This zone is called hyperemia because as a result of the injury, the body response mechanisms come into action and the blood supply to that area is increased. So that area is the area which is adjacent to the normal tissue, and it is hyperemic, having a lot of blood supply in this region. Between the zone of hyperemia and the zone of coagulation, there is a small area that is the tissue which is between the two abnormal sites and the hyperemic site, the coagulation site and the hyperemic site. This zone is called the zone of stasis. If we are having adequate resuscitation of the patient, with the passage of time, the hyperemic portion, it increases, the zone of stasis becomes more closer to the zone of coagulation, and the healing is healthy and early. If there is inadequate resuscitation, the zone of stasis, it becomes increasing in size, and there is thrombosis of the vessels in the zone of hyperemia also. And if there is inadequate resuscitation, what will happen, that zone of stasis will keep on increasing and it will press on the zone of coagulation. There will be thrombosis of the vessels in the hyperemic region, and the injury will become increased. There will be progression in the injury status or injury limit. So it is very important that once you are having such a patient, you should start the resuscitation from the very first time, because delaying in the resuscitation has bad impact on the overall survival or outcome of the burn. Okay, how
Hello,
we should
how are
see
you,
these
Doc?
patients.
Good
If
morning.
you are seeing a
Can you hear
patient
me?
in sorry. Can you hear me? Hello?
Yes, ma'am, clearly.
Okay. Now, if you see a patient as an emergency team in some area there is some burn and you are there as an emergency team there, so how you should see a patient, that this patient should be transferred to the burn center, or this patient should be kept in the house, or should be kept in a emergency setup for the time being, and then left for care at home. So there is a burn unit referral criteria, which is universal. And it is important that if you are having a burn center for the pediatrics, that is very good. You can send the pediatric patient there. But if not, you have to take care, because pediatric management is slightly different. The fluid resuscitation and the other management criteria, they are slightly different as compared to the adults. So burn injuries that should be referred to a burn unit, they should be a partial thickness burn greater than 10% of the total body surface area. Burn. The first degree burn, we'll discuss these classifications in detail, but just keep it in mind what is the referral criteria. Number one is the partial thickness burn, more than 10% of the body surface area. Any burn that involves the soft sides of the body, like face, hands, feet, and genitalia, perineum. These are called the soft areas of the body. So any burn that involves these soft areas like face, hands, feet, genitalia, perineum, they should be referred to the burn center. Then in any age group, if there is third degree burn, any patient of any age with electrical burns, including the lightning injuries, and the thunder and lightning injuries, they should also be referred to the burn center. Chemical burns, burns with inhalational injury, burn injuries with pre-existing medical conditions, because these pre-existing medical conditions like epilepsy or chronic problems of liver or the lungs, they can complicate the management, they can prolong the recovery and affect the mortality. So these patients, even if small burns, but there is a pre-existing medical disorder, they should be referred to the burn center. Any patient with burns and concomitant trauma like fractures, you should refer them to the burn center. Okay, and children, they should be sent if there is a setup in which they are treating the children, where there is no qualified personnel for the children, there is no pediatric doctor available. So those children, you should send them to the burn center. Burn injury in patient who requires special social, emotional, or long-term rehabilitative intervention. They have some social problem, or they are handicapped. So the patients who have special needs, they also should be referred to the burn center. So these are the 9-10 indications for how to refer a patient from a scene of emergency or from a primary care hospital to the burn center, the specific burn centers for the burnt patients. Okay, the types of burns we already discussed. The type of burns are according to the etiology. The scald burns because of the hot liquids, flame burns because of fire, flash burns because of the flash guns or the flash sprays, contact burns because of the friction, electrical burns because of the lightning or electric shock, chemical burns because of the gases or the chemicals, and friction burn, again, these are the contact burns. So these are the different etiological factors that can lead to burn in a person. Okay, now how we classify the severity of burn? We classify the burn as a minor burn, major burn, or a moderate burn. A minor burn is in any adults if the burn total body surface area burnt is less than 15%. You have not if you remember from your background knowledge of level 10, do you remember how we classify the body surface area in burns?
By the surface of the hand.
Yes, rule of 9.
Rule of 9. So that palm method, that is that we use this for smaller area burns, but for generally we use the rule of 9. I will discuss it a bit later. So the minor burn is when the total body surface area burnt is about 15%. And in children or elderly, it is slightly less. And the criteria is more threshold is low in these. It is about 10% in the children or in the elderly, or 2% body surface area burn or less, but full thickness in children, adults, without cosmetic or functional risk to the eyes, ear, face, hands, feet, or perineum. So in full thickness burn, if it is less than 2% body surface area, that can be called as minor. But if it is more than that and full thickness burn, then it is classified higher than the minor burn. Then in moderate burn, we have 15 to 25% of body surface area in adults, and the full thickness burn is less than 10% of the total. 10 to 20% of the patients of total body surface, 10 to 20% total body surface area burn, partial thickness in children. Less than 10% we said it is minor, but 10 to 20% is considered as moderate. And 10% total body surface area or less, full thickness burn. Up to 2% was in the minor, 2 to 10% is considered as the moderate burn. And what are the major burn? And keep it in mind that all the major burn patients should be transferred to the burn center for proper care. These are 25% of the total body surface area or more than that in adults, 20% body surface area in children or elderly, 10% body surface area burnt of full thickness. And if any burn that involve the eyes, ear, the soft body tissues, eyes, ears, face, hands, feet, or perineum, as these will lead to cosmetic disfigurement, cosmetic impairment. So these should also be considered as the major burn. All high voltage electric burns, I told you that referral for the electric burns is immediate. You should refer any electrical burn to the burn center specifically. And these electrical burns, they should be considered as a major burn because there are other factors involved in the body damage. So they should be considered as a major burn. Then all major injuries, all burn injuries which are complicated by major trauma, there is associated trauma, or there is inhalational injury. Again, they should be sent to the burn center. And all poor risk patients with burn injury, patients having comorbidities, having chronic medical conditions, they should also be considered as a major burn. Now, how to assess the burn size? We use the rule of 9 for the adults, and there is a modification of this rule of 9, the Lund and Broder chart. We use it for the pediatric population. And the palm method, you are saying the palm method, what is that? We close the palm in the form of a fist, and with the fingers closed, and the area which it covers is around 1% of the total body surface area. For smaller burns, we use this method. Instead of taking the whole part as 9, we use this palm size method and take it as 1% of the total body surface area. Okay, this is rule of 9. Okay, now you can see that we divide the body into different areas, all having the figure 9. And it makes a total of 11 areas that we take. The whole head and neck in adults is taken as 9. The whole upper limb, each of the upper limb is 9. If you divide abdomen and chest, this half of the, or anterior half of the chest is 9, anterior half of the abdomen is 9. And if we take the legs, the lower limbs, anterior half is 9, and anterior half of both the leg is 9, 9. When we see the posterior side, now the front was 9 and 9, chest and the front was anterior front of the chest was 9, back of the chest is also 9. Okay, this area is also 9. The front of the abdomen is 9, the back of the abdomen is also 9. The front of the leg is 9, The posterior part of the leg is also 9. The front of the left leg is 9. The posterior aspect is also 9. So now we have 1, 2, 3, 4, 5, 6 for the whole upper limb one side, 7 for the whole upper limb on the left side, 8 left leg anteriorly, sorry, right leg anteriorly, right leg posteriorly, 8 and 9, and then left leg anteriorly 10 and left leg posteriorly 11. So we have 11 areas. This is important to understand because your fluid resuscitation depends on the total body surface area you calculated from these charts. If you are taking it wrongly, your fluid resuscitation will be affected. Your fluid resuscitation depends on the total body surface area which you calculate. So this is very important for you people because you may be asked about it in the OSCE as well as in the exams also, how you calculate the body surface area for a person and then how you do the fluid resuscitation for that person. Now keep it in mind that what are the 11 areas which are having 1% of the total body surface area. These are the head and neck 1, anterior part of the chest 2, posterior part of the chest or the back of the chest 3, anterior abdomen 4, back of the abdomen 5, right upper limb 6, left upper limb 7, anterior half of the right lower limb 8, posterior half of the right lower limb 9, anterior half of the left lower limb 10, and posterior half of the left lower limb 11. So these are the 11 areas. You can be given questions like a patient presents to you with burn to the whole right upper limb and anterior half of the chest. Now, when it is said anterior half of the chest, what does it mean? Anterior, what do you mean by anterior half of the chest?
9%.
The whole area, this whole area. Yes, this whole area, and this whole area is not 18. 18 is front of the torso, the chest as well as the thorax, the abdomen. But when it is asked anterior half of the chest, it means anterior chest, not the abdomen area, not the back of the chest. So you have 9 and 9, 18. 9 for the whole right upper limb and 9 for the anterior half of the chest. So it's very important that you identify what is being asked in the question and then calculate your fluid assessment. Okay, for pediatric age group, it's already marked. For pediatrics, it's slightly different. Okay, sorry. This is and sorry, I left one thing. 1% is the perineal area. If there is a burn at the perineal region, 11 nines are 99. So 1% that is left is the perineal region. Okay, for children, the criteria is slightly different. Most is the same, but they're slightly different. First is the if we take the things that are the same, these are the limbs. Limbs are 9, just like we did it in adults. The upper limbs, they are 9, anterior, posterior, both. Okay, 9 for right and 9 for left. This is 4.5 of one half and 4.5 of the other half. So it is 9 in total for each of the limbs. Okay, then if we see the anterior half of the torso, it is anterior half is 18%, just like adults. It is 18% starting from the chest and the abdomen. But the back is different because in children the buttocks region is more prominent and the body surface area that is covered by that portion is more. So in total, if we take, it is 13% for the back, and for buttock region we have separate 5%. In total, it is almost equal, 18%. But out of those 18%, if it is just the back, it is 13%. And if it is the buttock region, it is 18%. And then lower limbs as compared to the adults, the lower limbs are slightly different because in adult we take it 9% anteriorly and posteriorly bilateral, but here it is 7%. The major difference is in the head and neck region. In the children, in the head and neck region, we take 9% anteriorly and 9% posteriorly. This is different as compared to the adults. So in children, the things that are different are in the head and neck region, and comparatively the abdomen and the back of the body is slightly different as compared to the adults. So this is the Lund and Browder's chart that we use for the pediatric population, and this rule of 9 is generally used for the adults. Now, how to calculate? Is there any issue in listening? Can you hear properly? Can you hear
Yes,
hear me?
we can hear. Yeah, we can hear. Yeah. People are writing in the chat.
Okay, it is giving me in the indication. Okay, I'm not seeing the chat actually. Sorry. Okay, how to estimate the burn depth? The burn depth is classified as the degrees. We have the shallow burns or the deep burns. The shallow burns are the first degree burns. The very slightest contact with the burn thing or burnt area causing just hyperemia. There is no tissue damage, there is no tissue loss, there is just hyperemia of the skin. We call it the first degree burn. The second degree burn are divided into two groups: the superficial second degree burn and the deep second degree burn. The superficial second degree burn, they are just like we discussed the scald burns in the children. They are called the superficial dermal burns or the second degree burns, and the deep dermal burns, they are the dermal burns that are deeper, going deeper into the dermis, and they are not very much scaldy like the superficial dermal burns. Miss Tamnata, I will go into it. Okay. What are the first degree burns? There is damage to the epidermis only. And these patients, they just present to you with hyperemia. There is redness because of the burn. They don't need any admission. They heal within 5 to 7 days. Only what you can prescribe them is some painkillers, and there is no scarring after the first degree burn. Okay. The second degree burn is important. Second degree burn is just showing this picture to you. This is the second degree burn picture, second degree superficial and second degree deep burn. If you see in the first picture, there is this zone of necrosis or coagulation, and then there is the zone of the viable tissue. In between the two zones, there is fluid collection. And this fluid collection appears in the form of scalds or blebs or blobs. So in these patients, there is necrosis, which is confined only to the superficial covering of that bleb or that scald. And the zone of stasis is filled with fluid. This area is filled with fluid, and it provides a sterile environment to the deeper viable tissue. The tissue keeps on growing from the sides, and the normal tissue, it regains its epidermis within some weeks, within a period of time, but there will be some minimal scarring with it also. Okay, so this is involving the epidermis and dermis. If you see this picture, this is epidermis, the green one. If I can make it a bit bigger. Okay. Where has it gone? Okay, this green portion, this is the epidermis, You can see the epidermal cells here, and these are the pits of the epidermis. And the portion that is pink in color extending from this green area till this yellow area, this is the dermis, and with all the dermal appendages also. This epidermis is the superficial layer of the skin, and then we have the dermis, and then we have the subcutaneous tissue. So we divide burn in the same way. The burns that are limited only to the epidermis, superficial epidermis, we call them the first degree burn. The burns that involve the epidermis and the superficial dermis area, we call them superficial second degree burn. The burns that involve the superficial dermis as well as the deep reticular dermis. This is the papillary dermis. You can see the papillary projections of the dermis here. This is the papillary dermis. So second degree superficial burn is till the papillary dermis. If it is extending into the reticular dermis, this is the deep dermal burn or the deep superficial, deep second degree burn. Now, to differentiate what is a superficial partial thickness burn or what is the deep partial thickness burn, they're also called the partial thickness burn. So superficial is epidermis and the upper dermis, the papillary dermis, and deep is epidermis and most of the dermis. Superficial partial thickness is painful because if you see in this picture, you can see that there are nerves that are coming and they are exposed by this burn area. The nerves are exposed and they are injured in, or you can say they become hyperemic or hyper stimulated in the second degree, in the superficial second degree burn. So the patient experiences more pain. But if the burn is extending till this region, the nerve will coagulate, it will lyse, and patient will not experience pain. So when the nerve is totally damaged, there will be no pain. But when the nerve is exposed and the superficial endings, they are exposed to the inflammatory substances, the patient will experience more pain. So how we differentiate between the superficial and deep partial thickness burns? That patient is having severe pain because of the burn. There is very severe pain. Patient will have swelling because of the scalds and the blebs. Patient will have fluid loss, and there are these scalds formation also. And these patients, if they are treated adequately, they heal within 2 weeks, and the healing is from the epidermal appendages. You can see this hair follicle here. It has the epidermal cells here. These epidermal cells, they help in growth of the epidermis. It not only grows from the edge of the injury, but it also grows from the epidermal appendages, and the healing is faster in the superficial second degree burn. But in the deep partial thickness burn, as you said, most of the epidermis and the dermis is lost. Patient is presenting to you with burn, but he's not in too much pain. There is no blistering. And if you see such a patient, you have to take it as a third degree burn. You have to treat it like a third degree burn, remove the external covering, do adequate dressing, fluid replacement, all the things, and try to reduce the inflammation as much as possible. These patients, as compared to the superficial partial thickness, they don't have scalds, or if there are scalds, they are very deep and they're not too much prominent as compared to the superficial partial thickness of the same degree. And if we talk about the outcome, these patient presents to you after the management and proper resuscitation and treatment. They present to you with bad cosmetic appearance, with ugly scars and sometimes hypertrophic scars also. So because the inflammatory response is prolonged in these patients. So how to differentiate a patient who presents to you with burn injury and you are saying that this is a superficial partial thickness burn or a deep partial thickness burn is in the history. First thing is you will ask from the patient, do you have pain? Or patient will tell you, I don't have pain. Then you will look at the swelling. If there are scalding, if there is blistering, that is a superficial thickness. If there is no scalding or blistering, it is a deep thickness. Color of both the burns will be the same. Color will be the same. It is hyperemic or slightly whitish, but the feeling of pain and the level of swelling will tell you, is it deep or is it superficial. Now we go on to the third degree burn. Third degree burn are easily different, distinguishable from the second degree burns. There is total loss of the epidermis, and all the epidermal appendages that are going into the dermis. And there is a marble-like appearance of the skin of the burnt area. What is marble? If you see the marble, it is flat white with some reddish streaks. So if you see these burnt patient, they will have reddish streaks because of the thrombosed vessels, and the color of the skin will be white, as compared to the second or the third degree burn. And these patients, they have destroyed tissues because of the severe coagulative necrosis. They are their burns are usually painless. You can manage them without patient feeling the pain, and their outcome is also not very good. There is very significant scarring, and these needs surgery for the management. Like you have to excise all the dead tissue, you have to debride it, you have to do the skin grafting afterwards, as well as in the post-op, even they develop contractures, they develop other cosmetic disappearances. So you have to correct them in the post-op period also. Okay, this you can see is a full thickness burn. You can see that epidermis is lost, the dermis is lost, the epidermal appendages are lost, and it is reaching up to the subcutaneous tissue. There is no dermis here. Now you can see in this picture, you can see the color of this of the burnt area. It is white. It is totally white, and you can differentiate it from the second degree burn, which is hyperemic. This is the second degree burn area, and this is the third degree burn area. This is hyperemic, and there is loss of tissue, and it is hyperemic. We cannot say it first degree burn, because first degree burn epidermis is intact. Here epidermis is lost, and we have this is healing. Actually, it is so it is not very clear for you, but it is hyperemic. And here what you can see is this is white area, and it is completely consisting of the unviable tissue, non-viable tissue. Now there is another classification. There is the fourth degree, that is more deeper to that, when the skin burn also involves the underlying structures. When there is injury to the muscles, to the underlying fascia or the bone, or there is charring of the tissue. This is called the fourth degree burn. Okay. Now, how to manage these patients? This we have already been covered in level 10. So I will go through it very quickly. The first aid that we provide in the scene of injury is you have to arrest the burning process. You have to provide emergency management to the patient. If there is flame burns, you have to cover the patient with the blanket and say him to roll, so that the burn that is affecting his clothes, it is subsided. If there is chemical burns, you should irrigate it thoroughly with a lot of water. Try to irrigate it. So copious irrigation is very important in chemical burns. If there is electrical burn, the first aid is try to take the person away from the area or the current source, because these patients, these person, when they are caught in a current field, they attach to it, and it is very difficult to take them away. So you try to keep yourself safe and push them away from the current source, and switch off the current if you have the main switches or the main electrical board is in vicinity, go and switch off the current of the whole area or of the whole place. Now, for any trauma, for any emergency problem, we have the ABCDE as the life preservation stay. So the first thing is you will take care of the airway, breathing, circulation. You will check for the deformities, and you will expose the patient to check for other injuries also. So you will do the ABCDE for the patient. If the patient is stable enough, you can ask about how he developed it, and if there is, we say, the ample history you can take. What is an ample history? Ask about the allergies, patient's past medical status, the last meal intake, patient's mechanism of injury, how he developed that injury. So this 4 or 5 questions you should ask at the spot of the injury. And it is not from the patient sometimes, because if the patient is unconscious, you can ask the person who are available at the site of injury, and all these things should be recorded. Then physical examination is important, as you have to rule out inhalational component. Inhalational component is usually in closed place burns. Like if a person is caught in a burn in a room that was closed, or in the car, there are chances that he inhaled the particles, and there can be carbon monoxide poisoning in that person. So you have to take care of the inhalational component of the burns. Then in physical examination, we estimate the depth while we are taking care of the patient. Estimate how much is the depth of the wound. Is it 1st degree, 2nd degree, 3rd degree, or the 4th degree burn? And then estimate the total body surface area burn also. What is the total body surface area according to the rule of 9? And if it is small, you can use the Palmer method also. And while you are transferring the patient, or while you are while you are looking at the patient and taking these 3 components, the inhalational component, estimation of depth, and the estimation of total body surface area, you determine whether the patient is having a severe injury, or a minor, or a moderate injury. If the patient is having severe injury, you have to triage the patient, and then you have to transfer the patient to the burn center. And meanwhile, if you have availability, you can irrigate and debride the wounds in the emergency setup also. So what is the acute management of the burn? We just discussed airway, breathing, circulation, disability, and exposure. If you see this picture, you can see this patient having burn of the body and burn of the facial region also. In this patient, it is very clear that this patient is suffering from inhalational injury. And to manage the airway, it is important to pass the endotracheal tube. If you delay the passage of the endotracheal tube, the whole of the nasopharyngeal mucosa, it will swell up. Even the oropharyngeal mucosa will swell up, and you will face difficulty in passing the endotracheal tube. So for endotracheal tube passage, you have to do it even if the patient is stable, patient is talking, and he's saying that there is no need. But keep it in mind, if it is a inhalational injury, you have to intubate the patient in the first instance. Don't wait for the edema to develop and the things become difficult for you and for the patient. Okay, can anyone tell what are the signs of inhalational injury? This is a patient which is very obvious, but in any patient, what are the signs of inhalational injury?
Shortness of breath.
Okay. Any other thing that is
burning of the
shortness
hair
of breath?
in the nose, and any burn around the orifices
Yes.
of the mouth and nose.
Yes, even if you don't, patient is normally talking to you, patient is not showing any respiratory problem. But if you see that area, there is some hyperemia in the area around the nose and the mouth, or there is burning of the hairs, there is curling of the hairs in the nasal, in the nose, or around the mustache area, you have to beware. It is a case of inhalational injury, and you have to keep the patient under observation, and this patient should be admitted. There are chances of having carbon monoxide toxicity, and you have to keep in hand oxygen and hyperbaric oxygen ready for the patient. And initially we started with just simple oxygen, and then if patient is developing symptoms, then we can put him for hyperbaric oxygen. Carbon monoxide is a odorless, tasteless gas, and it forms when because of the burning, carbon dioxide is carbon dioxide is replaced by the carbon monoxide. Why patient develops carbon monoxide poisoning is because carbon monoxide is more it has more affinity as compared to the oxygen in the hemoglobin. So what happens that if a person is exposed to carbon monoxide for a period of time, the carbon monoxide replaces oxygen and it binds with the hemoglobin, and patient develops CO toxicity. And the symptoms can be headache, cherry red lips, arrhythmias, acidosis, seizures, loss of consciousness. And what is the criteria of how you say that patient is having severe symptoms or minor symptoms that need specific hyperbaric severe symptoms needing hyperbaric oxygen therapy? It depends on the level of the carbon monoxide. If the patient is having a level of 0 to 5, usually they don't have any symptoms. At the level of 15 to 20, they start developing headache or confusion. At the level 20 to 40, they develop disorientation, fatigue, or hallucinations, or visual changes. Above 40, they develop hallucinations, and above 60, the patient is in shock and mortality is quite high. So what is the treatment of it is you give 100% oxygen via the nasal route, and patient should be intubated. He should be on ventilatory support if needed. Just keep it in mind that half-life of carbon monoxide is 5 to 6 hours. So if you do the initial resuscitation for this carbon monoxide toxicity for 5 to 6 hours at least, patient may become stable after that period. So if we give the patient 100% oxygen for 45 minutes, not the routine 4-liter oxygen, if we give 100% oxygen for 45 minutes, that improves the symptoms a lot. Okay, for breathing, inhalational injury patients should be intubated. There is another term, I think you have covered it in level 10 also, a patient who has circumferential burns. What is circumferential burns? Like burn that involves the whole hand, burns that involve the whole chest, anterior and posterior, burns that involve the whole legs, anterior and posterior. When the whole circumference of an area is burned because of the burn injury, the tissue contracts and there is a scar formation. This scar formation causes the compromise of the or it compresses the vessels and the nerves, and distally it causes vascular compromise or blood flow is decreased. So if you see a patient with a circumferential burn, it is very important that you perform escharotomy. What is escharotomy? It is not like fasciotomy. Fasciotomy is when you open the skin till the fascia. When you open the fascia, that is fasciotomy. But in burnt patient, we don't need fasciotomy. What we need is just give incisions to make the skin release its pressure so that it is not causing a band-like appearance around the chest or around the upper or the lower limb. Okay, if you see this picture, there is a scar or sorry, there is an incision on the lateral sides, right and the left lateral side, and there is an incision between the abdomen at the thoracic region or at the chest region. Okay, what is it causing? When it is too much tight, when it is too much compressed, it will cause slowing of the blood flow in that area, and it will cause ischemic necrosis. To prevent this, we release it by giving these release incisions. This is called escharotomy, and if someone asks you how to differentiate sclerotomy and fasciotomy, here we are giving insulin just in the skin. In sclerotomy, we are just incising the skin. In fasciotomy, the problem is in the facial compartments. So you have to reach the fascia unless until you cut the fascia, the deep fascia of the skin, you cannot release the tension, you cannot release the vascular compromise or the compression. Okay, if we talk about the non-surgical management of the burn, a patient who presents to you with burn injuries, you have to give them tetanus toxoid vaccine. You have to take care of the fluid. You have to give them nutrition. You have to provide them physiotherapy for the burn injuries and dressing for the wounds. Fluid resuscitation. Can anyone tell me how much fluid we should give these to these patients? How many fluid we should give to these patients? How we calculate the fluid need for these patients? How we calculate it?
Doctor, we use 2 ml multiplied by percentage of body surface involved in the burn.
What is this formula?
American Burn Association.
Okay. What is Parkland's formula? This formula is for the colloids, 2 ml per kg. This is for
Parkland formula.
sorry.
Parkland formula.
The initial burn management is by the crystalloids. The Ringer lactate is the best solution because Ringer lactate we call is the physiological saline. Its formulation is similar to the body plasma. The electrolytes it contains the sodium, chloride, potassium, and lactate. And the composition of these electrolytes is similar to the plasma. So we call Ringer lactate as physiological saline also. So the best fluid in the initial period is Ringer lactate. Then if we see a patient who is having some morbidities, comorbidities like hypertension and other things, in these patients, we have other options also, but generally Ringer lactate is the main solution that we use in these patients. In children, we use pediatric saline because children, they have different requirements. They need glucose also because their glucose concentration is, their glucose tolerance is less as compared to the adults. But in adults, we use Ringer lactate. And why we are not using the colloids in the first step or in the initial is soon after the burn injury, there is increased in the capillary permeability. Capillaries are more permeable, and whatever fluid you are giving, it is going into the interstitial spaces also. So if you start giving colloid to the patient, the colloid will go into the interstitial spaces and the edema will be multiple. So we don't give the colloid in the very first day of the burn. We start from the Ringer lactate and then gradually we shift to colloids. Why colloids are beneficial? Because colloids affect 3 times the effect of the Ringer lactate. We have to give 1 liter of colloid as compared to the 3 to 4 liters of Ringer lactate. So less volume is infused in the patient, and the gain will be the same. Gain will be the same for 4 liters of Ringer and 1 liter of colloid. But we cannot give it in the first day of the burn because of the leaking capillaries. And if we give it, the edema will be multifold. It will be more. So we use the Parkland formula, and it is weight in kg in total body surface area by 4 ml into weight into 4 ml per kg body weight per total body surface area burnt. Now I give you one question. If you come across a 70 years old male with 30% body surface area burnt, how much fluid you can calculate for this person? 70 kg man, 30% total body surface area burnt. calculate the fluid requirement for this person. Answer me in the chat. I will see where is the chat. Chat. Okay, answer me in the chat. I'm writing it in the chat box. It will be easier for you people. $70 kg man with 30% body surface area burnt. Calculate the fluid requirement of this patient for the first 24 hours. How 1.2 liter? Mohammed Samuel Maliki, how? What is 1.2? This is question mark. Is it ml or is it, what is it? Look at the formula now and then. $8,400. Yes, Saud Al Yabis. Yes, it is 8,400 what? Minute. What is it? ml. For 8,400 meals mean you have to give him 8 liters, 8.5 liters, or about 8.5 liter. So how we give this fluid to the person who presents to you with the injury? We calculate the time he underwent the burn. If he was burnt at 8 o'clock, but he comes to you at 10 o'clock, you have to start it from 8 o'clock. So from 8 to 8, whether he has reached you at 10 o'clock till 8 o'clock, you have to give him half of it, 4.2 liters in the first half, not 16 hours, in 4.2 in first 16 hours. Half of it, about 4.2 liters, we will give in the first 8 hours. Okay, half of it we will give in the first 8 hours. Sorry, I'm saying 8 to 8, 8 to 4 till 4 p.m. If the patient has burnt at 8 a.m., he is with you. Half of it you will give in the first 8 hours, and then 4.2 you will give after 4 p.m. till the next day 8 a.m. Okay, so half of the fluid will we give in the first 8 hours, and half we give in the next 16 hours. Okay, so we divide the time into 3 parts. In one third of the time of the whole day, or we can say in 8 hours, we give half of the fluid, and in the next 16 hours of the whole day, we give rest half of the fluid. And we calculate it from the time of burn. We don't calculate it from the time the patient presents in the emergency, the time of burn when he got that injury, not the time of presentation in the injury. And we use ringer lactate for it. Okay, I told you crystallites are preferred in the initial day, but then it is better to move on to the colloids, because if you give 8 liter to a person, it is too much as compared to the normal body requirement. So the patients having comorbidities, they can develop complications. So to reduce the fluid input in a person, you can convert crystallites into the colloids in the second day. And for the colloids, the formula is 2 ml instead of 4. 2 mLs per kg body weight per total body surface area burnt. It is the same. Okay. body weight. This is the formula for the colloids. Okay, formula is the same, but instead of 4 mLs, we take 2 mLs for the colloids. We give more colloids. We give colloid more easily and without any danger as compared to crystallites after the 24 hours is gone, because usually in the initial burn shock period, there is loss of this capillary integrity, and it settles within 24 hours. So after 24 hours, you can start the colloids. Okay. What is the criteria of monitoring? How can you monitor that your patient's fluid resuscitation is sufficient? For adequate resuscitation, we monitor it by the urine output. If a patient is maintaining the urine output of about 0.5 to 1 ml per kg in adults and 1 ml per kg per hour for children, we say the patient is adequately resuscitated. You can estimate for this patient, if this patient is having a weight of 70 kg, how much urine output is telling you that the patient is having adequate resuscitation. Answer in the chat box. How much urine output is a safe resuscitation parameter? Telling you about the safe resuscitation. This patient whose weight was 70 kg, how much urine output is considered adequate? (35 ml) what per day? 35 ml per day per hour. Okay, this unit is very important because 35 ml can be per day also. So if you are seeing such a patient with 35 ml per day urine, the patient is in acute renal shutdown. Yes, it could be 35 to 70. In this range, if the patient's urine output is in this range, it is safe. Okay. The difference is in electrical burns. If the patient is having electrical burns, for the kidney protection, we give more fluid. We give more fluid for resuscitation, and we have to maintain a urine output of 2 to 3 ml per kg. Now, this patient with electrical burn, we are expecting him to have about 140 to 180 ml per hour as a urine output. So for electrical injury, because we want to shower the kidneys, we want to make the kidneys safe from the damage, we make the patient overhydrated, and our response is a good urine output, an adequate urine output about 2 to 3 ml per kg in 1 hour. Okay, nutrition is also important in these patients, and the nutrition requirement is more in these patients as compared to the normal person, because burn is a catabolic injury. There is catabolism, the whole body go into the catabolic phase, and patient soon become depleted of the nutritional elements. So how we calculate the nutritional requirement of these patients? The daily requirement of a person is 20 kilocalories per kg usually, but in these patients we have to add 70 kilocalories per body surface area burnt, 70 calories additional per body surface area burnt. So a person who is having 70 kg weight, okay, for that person, how much kilocalories you should give him daily? Usually it is 25 to 40 kilocalories per kg, but we are taking it as a lower limit, 20 kilocalories per kg. Here we are taking it as a limit. So a 70 kg man should have 1400 kilocalories as a general. But if he had 30% body surface area burnt, he should receive additional calories. How much is the additional calories for the same patient? Read this line about the daily requirement and calculate now the nutritional requirement for this patient. This is the caloric requirement. 20 kilocalories per kg will be the basic, plus 70 kilocalories per the total body surface area burnt. Now tell me, what is the caloric requirement for this person? How much will be the total calories that you will give to this person in one day? Twenty kilocalories and 70 kilocalories, 20 kilocalories per kg and 70 kilocalories per total body surface area burn. So how you will calculate the baseline? You will multiply 70 and 20. It is around 1400 kilocalories. Okay, so 1400 kilocalories is the baseline for the patient. But for his burn injury, you have to give him 70% of the total body surface area burn. You have to multiply 70 by 30. We have 70, we have 30 as the total body surface area. So you will get 2100 here. So how much is the total? It is around 3500 kilocalories in one day you have to give to this patient. And these are non-protein calories. Protein you have to add separately to these patients. And for every usually what the routine we follow is we follow the routine of giving nitrogen 150 calories to 1 gram of nitrogen, or about 150 kilocalories. We give 6.25 gram of proteins. So you have to calculate proteins according to that. And you have to add a protein requirement of about 3 gram per body surface area burnt also in the burn patient. If a patient is receiving 20 kilocalories of the non-protein calories, you have to give him 1 gram per kg protein also. And this patient should receive 70 gram proteins, protein diet 70 gram. But with that, you have to add the body surface area burnt protein also. How much these will be? 3 into 30, almost 90. So 90 and 70 around 150 or 160. 160 gram proteins you have to give daily to this patient. Understand?
Doctor, this is the protein is above the regular amount.
This 1 gram per kg is taken as baseline. This is less than the normal, but this is taken as a baseline for the burnt patient because we have to add the body surface area burnt protein also. So we give them 1 gram per kg as the baseline, and in it we add 3 gram per the body surface area burnt.
I understand. Thank you.
And along with these, we have to give them vitamin supplement, vitamin C, zinc, and multivitamins, as these are the mediators of the repair work, and they are in need for the skin integrity in the later outcome of the patient. Now, non-surgical burn management also include. Okay, non-surgical burn management also include some splints if the burn is at the area where there is joint in between. You can give splints to protect the development of the contractures in that area. We can advise once the patient is safe from the initial injury, you can advise exercises for the rehabilitation so that the range of motion in that joint area is better. And if the patient is prolonged bedridden because of the burn injuries and you cannot make him move about, then it is important for the patient that he should be turned right or the left side frequently. Every hour you should turn him to the right, and the other hour you should turn him to the left side to avoid the pressure ulcers formation. Okay, this was the non-surgical management. Now the burn management is itself, it includes cleaning and debridement of the dead tissue, and on daily basis we have to reassess the burn. If we are getting hyperemic healthy growing skin down there, we can plan for grafting earlier. If we see that the epidermis is going to develop and there is hyperemia in that burn tissue region, we can go for earlier skin grafting. Dressing changes are also very important, and what is the reason why should we cover the patient is to protect them from the external contamination of the wounds. Okay, usually we use flamazine. This is the most common ointment that we use on the burn patients. It is actually silver sulfadiazine, and it is applied daily on the skin. And there is some other preparations also, like fusidin, which have bacterial cover also, or bacitracin. We can use them, but the best treatment is silver sulfadiazine in the areas other than the skin, other than the face. In face, you can use fusidin or bacitracin, but in the rest of the skin, flamazine is the best. Okay, we have discussed the scar, why we are doing the sclerotomy, because there is vascular compromise and we have to get rid of the pressure on the vessels. Otherwise, there will be ischemic necrosis. Okay, we do grafting in these patients, and grafting can be superficial thickness skin grafting or full thickness skin grafting. If the patient is presenting to you in the early phase and you want to save time, you can go for superficial thickness skin grafting. It is usually what you say, that this is not involving the whole layer of the skin. It just involves the epidermis and the papillary dermis or the superficial dermis. You can take it, and it can be applied in the form of net on the skin. We take a piece and then we mesh it. Mesh it means we make several incisions on it. You can see that they have made it like a net. They made many incisions in it, and it is like a net. With the making of this as a mesh, a small part, like if it is of 1 centimeter or a 2 centimeter skin graft, we can expand it to almost 3 to 4 centimeter. So by meshing it or by making these incisions in it, we are actually increasing the width or the diameter of this graft. Okay, so you can take it from the person's own skin, from any unburnt area. We can take it from the lower limbs, abdomen, or the buttock area, and it can be infiltrated with the adrenaline. If you are using it on the face, better to take it from the scalp, because the color of the scalp and the skin of the face, they are the same. And you can fix it with the staples or with the sutures. Important thing is post grafting care, because these grafts, they are very good. They are very quick in healing, and they develop into skin quickly. But if they get infected, the whole graft will become just a piece of shit. So you have to be careful that when you are grafting a patient, you should be taking care of the infections also. It should not get infected. This is the appearance of graft. You can see that this net-like appearance or this mesh-like appearance is because of the incisions we gave in the skin, and the small skin sample or the small skin graft that we took, it has expanded and covered a big area. What is it doing? Why we are giving these grafts? These grafts, when we place them in the area of burn, they take nutrition from the underlying tissue or underlying hyperemic tissue, and then epidermis start growing from all around the area, from all the edges of this graft, in between the meshes, as well as from all the area. That's why you can see in this picture, you can see it is having the appearance of a mesh, appearance of a net, shabaka. Okay, so this is because of the epidermis that grows from all sides of this graft. The grafts took place. It got its nutrition from the underlying hyperemic tissue, and then all the way epidermis started growing from it. Okay, in face, the skin grafts, they heal with no surgery. We use unmeshed graft because we don't want scarring on the face. So we use mesh from the scalp, and we usually use it unmeshed. We don't make incisions in it. For hand, because we have to preserve function again, so we try to use unmeshed skin because the meshed skin will have more contraction. It will try to have some what you can say, that the skin will be more tense in the meshed skin graft, because it has to cover a whole big area, so it tries to become more contracted. So in the areas where we want to preserve the function, where we want cosmesis, we don't use the meshed graft. Okay. Now, if we talk about chemical burns, the chemical burns, we said one thing before, that you have to do copious irrigation. The best thing is when the patient has some chemical spilled on his hand or on his extremity or anywhere on the body, the best thing is irrigate with copious amount of water. Then if there is no inhalational injury, there is no organ injury, it is better because they have good chances of getting uh, away with that problem. If there is poison, you can give an antidote. If there is a poisonous material, you can give an antidote for it if available. If it is an acid, again you have to treat it with saline water or with alkaline water. If it is an alkali, try to wash it with water. No need to give any acid to counteract the signs, to counteract the effect of the alkalis. So for alkalis, just give water. For acid, we can add salty water. We can give salt in the water, and we can irrigate it with it. For electrical burns, this is also, we just discussed that why electrical burns are important, because their contact area may be small, but the damage is too much. So you have to always refer these patients to the burn center. Number two, when you are resuscitating these patients, resuscitation is more as compared to the normal person. We add 30% more to the body surface area if there is electrical burns. Then you have to take care of the cardiac activity of the patient. ECGs are recorded, ECG monitor is attached, and ECGs are visualized every now and then. And for these patients, you should maintain a urine output of about 2 to 3 ml per kg per hour. Okay, these patients, they have they are more prone to develop acute renal failure, so you have to take care of the cardiac as well as the kidney status. Okay, this is all about the burns. The important things in it that you should know: how to calculate the burn fluid management, how to calculate the burn fluid estimate, and how to calculate the calories for these patients, and how you classify the burns by depth, how you calculate the total body surface area burnt, and what are the presentation of different types of burn. If you are having a patient with 2nd degree superficial burn, how it will present to you. If you have a patient of full thickness burn, how he will prevent you. Then inhalational burns is also very important. What are the signs that tell you that patient may have inhalational burn? Then electric burns, the important things that we discussed about the electrical burns that can come in the form of some question or in the form of some scenario. So these are the important things that you should cover in this burn lecture. This was the major lecture today, so I took more time on it. The other 2 lectures, they are the skin and subcutaneous tissue is also important, but it is not so big. But the pediatric plastic is, inshallah, it will be a very small lecture for you. So now you can take a break of about 10 minutes, and I will restart the lecture at 5 to 11, inshallah.
Doctor, I have a question.
Yes.
Would you please repeat the how do I calculate the calories?
What?
And how much fluid should I give a burnt patient?
Okay. Just a minute. I will give you a scenario and okay, I will give you a scenario. Keep this thing, this picture in mind. Where is that picture? Keep this thing in front of you. Okay. What is it? 4. This one I will write it easily for you. 4 into weight into BSA, whatever is the percent BSA. Okay, this is what you should keep in mind. Okay, if I say you there is a patient who has a weight of about 60 kg and he is 60% burnt, how much fluid you will calculate? Now what you have to do, you will write 4, you will write 60 here, and you will write 60 here. 60% is the body surface area burnt, 60 kg is the weight. So what is your calculation in actual? 4 into 60 into 60. This is the total amount that you will get. Now you can calculate it and you will get the total fluid in mLs per day. This is per day. Now we say, I will calculate it for you. This is 3600 into 4. This is around 1440 ml. Okay, 14 liter ml almost. Okay, now this patient needs this fluid in 1 day. 1 day means the day if he got an injury at 8 a.m. till the next day's 8 a.m. he should receive this much fluid. Next day's 8 a.m. Out of this fluid, how much fluid we will give? We divide it into 8 hours and 16 hours period. So the initial half of the fluid is around 7,200 ml, around 7 liter. I will give in the first 8 hours. The next half, the 7,200 ml, I will give in the next 16 hours. This is for the normal fluid replacement of a burnt patient. Okay, this is called the Parkland formula. This is Parkland formula. 4 into weight into body surface area burnt. Now you understand it?
Yes, doctor. Thank you so much.
And if we talk about calories in the same patient, if we talk about calories, which I will explain it here, it will be easy for you. Calories you read in nutrition also, the normal body calories are 25 to 40 kg, 25 to 40 kilocalories per kg body weight. This is the normal. For these patients, what we take around 20 kilocalories per kg. This is their baseline, okay, per kg. Means this person was 60 kg, so I will give him around 1200 kg, so 1200 kilocalories as a baseline. But along with it, what we have to give? We have to give him 70 gram per BSA, per body surface area. Now, his body surface area burnt is 60. So what we get here, 60 into 70 is around 4200 kilocalories. Okay, we get here 4200 kilocalories. Now, these 4200 kilocalories will be added to 1200 to meet the nutritional requirement for this patient, to meet the caloric requirement. If you just give him 1200, the patient is in severe catabolic phase. He will become malnourished and he will become more prone to develop the complications. So you have to give him almost double or more than double additional amount to cope with the burn stress. Okay, this is what we say is almost normal for that person. But now, as he had 60% body surface area burnt, these 4200 kilocalories should be supplemented. They should be supplemented to him, and his total requirement is, or his total caloric requirement is now 5400 instead of 12. It is almost 3 to 4 fold increase now.
And how much time should I give him this?
This is per day.
per day.
Per day, yes.
Thank you,
And
doctor.
And with the passage of time, if the patient is improving, we reduce it with the passage of time. But this is in the initial phase, it is per day. We don't cut short it. Okay, take a 10 minutes break, inshallah, and I will start it at.
Doctor, 15 minutes is good to make some breakfast.
Huh?
15 minutes, doctor, please.
I started at 9. Acha, how much time you want to
Hello.
15 minutes, doctor, to make breakfast and some coffee.
take? Okay. Okay, I will
Hello,
come
how are
back.
you?
Hello.
Hello.
Yes.
Hi, how are you? Good morning.
Alhamdulillah.
I'd like to tell you something actually.
Yes.
I have noticed that you just focus on the epidemiology and the basics. As we are on the level 12, we don't need all of this information, and it is all basics. So why you're not focusing on the management? And you have to pick up every management with a case is going to be better. Just
Yes,
you
I
have
will
already
give you the case, inshallah, at the
So-
end of today's session. I will give you the cases. That will
honestly, the
Yes.
way the way you lectured, the lecture was very boring a little bit. You was talking a lot, and actually you go and reading over and over. I can't read over at home.
the
I
thing
need
is,
your knowledge,
the
that
thing
clinical
is,
knowledge
if
too.
you don't know, if you don't know the basics, just like we discussed it yesterday, if you don't know the anatomy of the hand, how can I just speak out all the things and give you the spoon feedings? You should have to use your own brain. If you don't know what is the superficial thickness grafting, how it looks like, how it appears, I know you have covered it in level 10, but I'm sure only few of you remember what is superficial partial thickness burn. Even some people, they don't know what is a scald, what is a blistering. These things, I prefer that you should know these from the beginning, because this you have already covered in your basics or in your level 10. But most of the students, they don't know about it. That's why we have to start it from the beginning, and it takes more time as compared to the main text. This takes more time. Your management and your resuscitations and your surgical managements, they are not taking much time. But if you don't know the basic, we have to revise the basic also. If I directly start, okay, how much burn area, this is the first degree burn, this is the second degree burn, then the student will start asking, what is second degree, what is first degree? So I have to start from the baseline. Even I have to tell what is the skin. I think many of you don't know the anatomy of the skin. Just now we will take the other lecture, and I will ask
We
about
agree
the
with you,
layers of
doctor.
the. Yes.
We agree with you, doctor. Your way is the best way. Thank you, doctor.
Okay, take your break.
Anyway, thank you for your clarification. Thank you so much. But I'd like you to change the way of lecturing. It's gonna be
Yes.
better and
No,
be
doctor,
boring
please
all
don't
the
Why I
time.
change,
say,
doctor. We like your way, doctor.
why I say you to before the lecture, read the anatomy and the physiology part. If you come up with that, then my process will be changed, because I don't have to waste time on the epidemiologies and the anatomy and the physiological part of that lecture, because this is the basic. If you know the basic from the beginning, from the start of the lecture, if you answer me about that, we know this, continue ahead, then I will skip those things. But I have to do read on these are just reading on. I have to read these things, because I know all the students, they don't go through the topic from the beginning. So we have to keep the same sequence, just like we were doing in the level 10, starting from the epidemiology, etiology, and the pathophysiology. We have to repeat the same sequence, because the students, they forget. 1 year passed and they forget the previous thing. So we have to repeat these things. Hope you will not you will get something from this at least. So inshallah, when you will see the case scenarios, the things will be more comprehensible for you, inshallah.
Okay, thank you so much. I appreciate it.